Good morning. My name is Megan. I'm one of the chief residents. I have the pleasure of introducing today's speaker, Dr. Betty Kolod. Dr. Kolod is an assistant professor in our Division of General Internal Medicine and the Division of Preventive Medicine and Community Health in the Department of Environmental Medicine and Climate Science. She trained in the Primary Care and Social Internal Medicine Residency Program at Montefiore and here at Mount Sinai in the Public Health and Preventive Medicine Residency, of which she is now the Associate Program Director. She practices primary care and drug user health in the REACH program and teaches advocacy skills and public health approaches to substance use in the School of Medicine and Master of Public Health programs. Dr. Kolod is active physician advocacy and organizing for universal health care and other social justice struggles with an emphasis on community leadership and collaboration. This month, she assumed the role of chair of the board of the New York Metro chapter of Physicians for a National Health Program. Please join me in welcoming Dr. Kolod.
Thank you so much. Good morning. Thank you. Thank you for your interest in exploring Medicare, the legislative milestones that have shaped this public coverage program, and considerations for expanding coverage. I plan to cover several topics and have time at the end for discussion, so please make note of your questions and comments. We have many experts in the room and on Zoom, including those of you who have advised loved ones when selecting a Medicare plan or entering Medicare yourself. So I may not know all the answers to your questions, as this topic has many complexities, but I look forward to a lively dialogue. I have no financial disclosures, but as mentioned, I have a leadership role in the New York chapter of Physicians for a National Health Program, or PNHP, and we'll use several slides from Ed Weisbart's beautiful and publicly available Medicare Advantage slide deck and PNHP reports on Medicare Advantage. This morning, we will cover a very brief history of Medicare, our tax-funded program that provides coverage to all Americans over the age of 65 and some other groups. We will explore Medicare Advantage, the Medicare program that is administered by private for-profit insurance companies, and look at the evidence that Medicare Advantage raises costs and provides less health care and increases administrative burden on us. And we will take a look at two approaches to increase the number of Americans with comprehensive health coverage toward the goal of achieving universal health coverage. First, why am I talking about universal coverage in the United States? Is that controversial? I want to start by bringing your attention to this 2020 position paper from our professional society, American College of Physicians, that plainly stated support for achieving universal health coverage, either through a public option, like an expanded access to Medicare, or via a single-payer system that would use tax dollars to provide one healthcare plan for all Americans. This is often referred to as improved Medicare for all. Society of Internal Medicine followed suit and endorsed the ACP policy. Okay, so what are we missing out on as the only wealthy capitalist democracy without universal coverage? When we compare our health outcomes to other wealthy capitalist democracies that have universal health care, we have the shortest life expectancy. That is true whether you're looking at countries like the UK, where taxes pay for health care and physicians are employed by the government, countries like Canada that have tax-funded comprehensive health care for all, but with private hospitals and providers, their version of Medicare for all, also called a single-payer healthcare program, or countries like Germany that achieved universal coverage through a network of public programs and private, nonprofit, highly regulated insurance plans. These are data from 2012, but the trend has not changed, and I like this representation by universal coverage model. At the same time, our peer nations all pay less for their universal health care. Again, older data, but we now outspend peer nations by at least 2 to 3 times. So we're now oriented to approaches to universal health care. Briefly looking at newer data, it really drives home the difference. We see here that healthcare spending per person on the x-axis, with most peer countries spending between $3,000 and $5,000 per person, and life expectancy at birth on the y-axis, As our life expectancy flattens out compared to peer nations, and our expenditures continue to rise, now over $12,000 per capita, driven by our higher administrative costs compared to other countries, we can take note that the increases in spending were punctuated by policies that have invited private for-profit insurance companies into our healthcare system. Let's discuss Medicare. As mentioned, Medicare is our Canadian-style tax-funded health coverage program. Many of you know this story, but until 1965, private health insurance was linked to employment, and when workers retired, they lost their coverage right when they needed it most. In 1965, President Lyndon Johnson worked with the Democratic majority Senate and House to pass this public program to cover all Americans over the age of 65. An interesting historical note, Medicare required hospitals to abide by the 1964 Civil Rights Act and admit Black patients into segregated white hospitals in order to receive Medicare funding. Thus, Medicare triggered the rapid desegregation of about 7,000 American hospitals. And I'll move through this slowly so we know which is Part A and Part B. But when it passed, Medicare consisted of two parts. Part A on the left to cover hospital care, short-term SNF stays, and hospice, and Part B on the right to cover clinician fees and outpatient care, and also preventive services. Part A was paid for by a new tax on all employers and employees, and Part B premiums came out of the patient's Social Security check. Today, that premium is at least $170 a month. Parts A and B are both fee-for-service, meaning providers are compensated for each service provided. To control costs and dissuade people from using too much health care, Medicare was designed to pay 80% of the medical bill, leaving patients with a 20% copayment. We'll talk about this later, but this is why gap insurance or Medigap is offered by private insurers to cover those 20% copayment costs. Medigap plans are also important for covering Medicare deductibles, which today are over $1,600 for Part A and $240 for Part B. And this is just per benefit period, which is complicated because it can be less than a year. Finally, physician compensation would be determined by a federal agency called the Medicare Payment Advisory Committee, or MedPAC. Even though physicians would continue to be employed by hospitals, practices, or to be self-employed, not to be employed by government like in the UK National Health Service. Then in 1972, Medicare is expanded. Previously, it only covered people over 65, but at that time, people on dialysis and people who were disabled for at least 2 years received coverage too. In 2001, people with ALS are also covered. The next update comes in 1997. As an additional cost reduction measure, the Clinton administration creates an alternative to traditional fee-for-service Medicare, Medicare Part C, or the Medicare Plus Choice Plan. So this is an alternative to Part A and Part B that is administered by private for-profit insurance companies on a capitated basis. The insurance companies receive public Medicare dollars for each enrollee, and then they can keep a portion of the savings. And this guarantees profit for the company, increasing interest in insurance companies in participating. The goal was to incentivize the private sector to keep costs low through innovation, while providing enhanced benefits like reduced out-of-pocket costs, dental, gym memberships, to draw customers in on the free market. In 2003, the Bush administration changed the name of the program to Medicare Advantage to distance it from the reproductive health care debate. They also increased payments to private insurance companies to retain their interest in the program. The same law in 2003 created Medicare Part D, a voluntary drug coverage program for Medicare beneficiaries. To receive this coverage, beneficiaries have to pay a monthly premium. Today, that's about $55 a month. Or they can opt for Medicare Advantage and pay one lower price for Part A, Part B, and Part D benefits, plus the bonus services that we talked about before, all rolled into one. This also created opportunities for pharmacy benefit managers and other middlemen companies to get in on healthcare for millions of seniors. Here we see that, can you see my cursor? Here it is. Oh, okay, thought I was pointing to things. Here we see that only 1/3 of our Part D spending goes to drug makers, and we see other middlemen are receiving a significant portion of that spending. This law also bars Health and Human Services from interfering in the free market by leveraging Medicare's 65 million covered lives to negotiate for drug prices that are lower. So it bars that. All right, so now let's pivot to Medicare Advantage. As it has grown over time, let's examine its effects. 25 years after its inception, are private insurance companies bringing about the intended cost savings? First, a pictorial representation. In traditional Medicare, everyone pays taxes into the Medicare Trust Fund, and then we all get paid for providing health care. This is efficient, with only 2% going to overhead costs, and there is a wide network of providers who accept traditional Medicare. In Medicare Advantage, our tax dollars first go to insurance companies, then they create contracts with a limited set of hospitals and providers, and only pay those providers who are in network. The overhead is much higher than traditional Medicare at around 15%. Here is another representation of the higher overhead costs of Medicare Advantage plans. Here we see the percentage of Medicare dollars spent on non-medical services like administration, marketing, and profits. All the way on the right, traditional Medicare is spending 98 cents of every Medicare dollar on medical services, similar to the efficiency of the Canadian Universal Healthcare Program. Insurance companies are instead spending about 85 cents of each healthcare dollar on medical services. Okay, so this slide gets a little bit complicated, so bear with me. But let's look at how Medicare Advantage profit margins are set. It begins with Centers for Medicare and Medicaid, or CMS, determining the average cost of care per traditional Medicare patient. Let's see how this. There we go. So they determine the average cost per traditional Medicare patient, and this sets a benchmark for expected spending. Then each Medicare Advantage plan submits a bid to CMS for the price at which they think they can deliver the same benefits as traditional Medicare. If they bid below the benchmark, then they are allowed to retain about 2/3 of that gap as what's called a rebate. CMS keeps the other 1/3. The Medicare Advantage plan is expected to use some of their rebate to either lower beneficiary, don't worry about that, to either lower beneficiary out-of-pocket costs or to offer those additional benefits that we talked about. If the Medicare Advantage plan bids above the CMS benchmark, then they are required to charge a premium to patients to make up the difference. This is not a common occurrence, and the Medicare Advantage plan is thus incentivized to keep their bids as low as possible. Okay, so as we see in these data from the Medicare Payment Advisory Committee, or MedPAC, the government entity that sets Medicare rules and fees and reviews Medicare finance, Medicare Advantage plans have seen increased rebates over time. But at the same time, the proportion of the rebate that is spent on lowering out-of-pocket costs for patients is declining. According to MedPAC, as we see on this graph of the percentage of Medicare Advantage rebates that are spent on reducing out-of-pocket costs, we're seeing a decline from 43% in 2022 to 39% of out-of-pocket costs, of rebates being spent on out-of-pocket costs in 2023. So let's break down how this works. Medicare Advantage plans have an incentive to keep out-of-pocket costs high. Reducing out-of-pocket expenses like copays would remove the financial barrier to healthcare and allow beneficiaries to use more healthcare services. This is called induced utilization. So by keeping out-of-pocket costs high, insurance companies keep health utilization lower and keep more tax dollars as profit. Additionally, Medicare Advantage rates are set according to the expense of an average traditional Medicare patient. But Medicare Advantage attracts the healthiest and least expensive patients. We see in this graph from a Kaiser Family Foundation analysis that among patients who had traditional Medicare in 2025, those who went on to switch to Medicare Advantage had lower medical expenses the year before they switched. So those who switched to Medicare Advantage in 2016 had $1,253 less expensive medical needs compared to those who stayed in traditional Medicare. So this study suggests that healthier people are the ones who choose to switch into Medicare Advantage, contributing to cost reduction through favorable selection. People who recently turned 65 and healthier people receive more marketing, more on that later, and may be attracted to benefits like gym memberships. At the same time, sicker patients may be wary of the narrower networks and prior authorizations of Medicare Advantage. We'll talk about that more later also. And they may choose to avoid Medicare Advantage as a result. This is also true of sicker patients who leave Medicare Advantage because they cannot access the specialty care they need. So these last two slides covered the concept of favorable selection and limiting induced utilization that are strategies used by Medicare Advantage to spend less of tax dollars they receive on healthcare. Finally, you may have read about Medicare Advantage upcoding scandals, like home visits by nurses who assign patients several illnesses that they may not have or that they are not receiving care for. This is happening because Medicare payments to Medicare Advantage plans are also based on the patient's individual risk score. And this is based on the diagnoses that providers code. So in fee-for-service traditional Medicare, there's little incentive for providers to record more ICD-10 codes and make the patient appear as sick as possible. And Medicare Advantage, there are financial incentives to urge providers to record all possible diagnoses because they raise the individual risk scores and also result in higher payments to the plan. In fact, the first year switching from traditional Medicare to Medicare Advantage, patients' individual risk scores sharply increase. In a 2021 analysis of Medicare Advantage risk scores, they were about 11% higher than those for similar traditional Medicare beneficiaries. You can see on this graph from Kaiser that this upcoding results in excessive payment to Medicare Advantage, which reached $23 billion last year. In summary, Medicare Advantage costs more due to large and growing rebates, coding intensity, and favorable selection. According to MedPAC, so the federal government, $88 billion of extra spending in 2024. So now let's look at the experience of patients and providers under Medicare Advantage. So first of all, according to MedPAC, over half of eligible Medicare beneficiaries are now in a Medicare Advantage plan, and the proportion is projected to keep rising. To paraphrase Don Berwick, if an ice cream company is getting a government subsidy, they can offer free ice cream, everyone will want it. That does not mean it's better ice cream. It just means that it's free. In fact, this analysis of Medicare Advantage encounter data and traditional Medicare claims data published in Health Affairs last year found that healthcare resource use was considerably lower in Medicare Advantage than in traditional Medicare across diagnoses. This effect was most pronounced for treatments, meaning that Medicare Advantage patients were getting less treatment than traditional Medicare patients. This reduction in treatment utilization surpassed the higher use of imaging in Medicare Advantage across all conditions to arrive at the differentials seen in this graph. If you have ever ordered a CT for a Medicare Advantage patient, you probably have a theory about higher imaging use among Medicare Advantage patients, but we'll come back to that later. All right, so I alluded to narrower networks of Medicare Advantage plans. This is a 2019 analysis of network data for 421 Medicare Advantage plans covering over 20 million enrollees. And it found that few mental health and behavioral health providers, cardiologists, psychiatrists, and primary care providers were in network. We see here that almost 50% of PCPs who work with Medicare patients in this analysis were out of network for Medicare Advantage. Over 70% of Medicare Advantage beneficiaries find that at least one of their providers is out of network. All right, so what is the effect of these narrow networks coupled with the heavy prior authorization burden of Medicare Advantage, which we'll talk about more in a second? This 2023 retrospective cohort study of over 75,000 Medicare beneficiaries found that more Medicare Advantage beneficiaries wait longer than 2 weeks for surgery after a cancer diagnosis. So we can see the proportion of traditional Medicare enrollees who are waiting more than 2 weeks compared to Medicare Advantage in the dark blue. On top of having to wait longer than people in traditional Medicare, cancer patients in Medicare Advantage are far less likely to have their surgery at an NCI-designated center of excellence. Due to narrower networks of Medicare Advantage plans, they were more likely to have their surgery done at hospitals that are less experienced in these complex surgeries. These delays and limitations to specialized centers were associated with increased mortality. Note the nearly 2 times higher mortality for Medicare Advantage recipients with pancreatic cancer in this study. At the same time, as the number of Medicare Advantage beneficiaries rises, hospitals are pulling out of Medicare Advantage plans in response to unfavorable rate negotiations that are made possible by the increased market penetration of Medicare Advantage. So as we said, the large number of Medicare beneficiaries who are on Medicare Advantage plans, and also the heavy prior authorization burden. Here we see a list of entire hospital systems that have pulled out of Medicare Advantage networks entirely. The collapse of Medicare Advantage hospital networks is an emerging disaster for patients and a direct consequence of the business model of Medicare Advantage. Okay, so I promised we would talk about prior authorizations. So let's look at some of the factors that affect delays and denials in Medicare Advantage. Medicare Advantage plans reject prior authorization requests for services that were medically necessary by applying internal clinical criteria that are not contained in Medicare coverage rules. For example, in an Office of the Inspector General report, it is noted that a Medicare Advantage plan can deny a CT because they require an X-ray first. Traditional Medicare does not have criteria that require other imaging before a CT and would pay for the CT without requiring the X-ray first. It's sad, so few of my patients have traditional Medicare that I think of a prior authorization for a CT as the norm. And this high denial rate, this 18% of Medicare Advantage claims that were denied that would have been approved by traditional Medicare, these are data from before the scandal of artificial intelligence being used to deny claims and prior authorizations. Okay, so nearly all Medicare Advantage enrollees are in plans that require prior authorization for some services. More than half of Medicare Advantage plans require prior authorizations for skilled nursing stays inpatient hospitalization, hearing and eye exams, mental health, substance use services, and drugs that we administer in the office. When I see a patient with Medicare Advantage at the REACH program, I know it will be nearly impossible to convince their plan to cover long-acting injectable medications to treat their substance use disorder. This challenge is unique to Medicare Advantage and commercial insurance. Again, I'm accustomed to prior authorizations because so many of my patients have Medicare Advantage. In fact, recently I had to do a prior authorization for metformin for a patient on Medicare Advantage. But that is not the case for traditional Medicare. Prior authorization is rare in traditional Medicare. Okay, so let's summarize the challenges that patients and providers face as delays and denials. Next, let's briefly address the claim from AHIP, which was formerly known as America's Health Insurance Plans, which is a trade organization representing insurance companies, that placing more limitations on Medicare Advantage would harm Black, brown, and low-income Americans. All right, so an AHIP demographic data report from 2021 showed that while 44% of Medicare beneficiaries are on Medicare Advantage at that time, we know it's more than that now, 54% were Black, and 54% of Black Medicare beneficiaries are on Medicare Advantage, and 55% of Latinx Medicare beneficiaries are on Medicare Advantage. This report also showed that more low-income Americans, Medicare beneficiaries are on Medicare Advantage, as we might expect. But concerningly, Medicare Advantage beneficiaries experience significantly more trouble accessing care due to financial barriers. So as shown on the leftmost bar graphs, so this is in dark blue, the higher proportion of Medicare Advantage beneficiaries who have financial barriers to care. But then if you compare white, Latinx, and Black Medicare beneficiaries, we see an even more pronounced degree of cost barriers for Medicare Advantage beneficiaries of minoritized populations. While the difference in cost-related problems by race and ethnicity in both is seen in both traditional Medicare and Medicare Advantage, and that's indicative of a larger systemic problem, the fact that Medicare Advantage is exacerbating this difference tells you that Medicare Advantage is not the solution to inequity. You may think that Medicare Advantage recipients face more poverty, and that is the explanation for this trend. But the trend is found across income groups. People in Medicare Advantage have more problems with medical bills and medical debt than do people in traditional Medicare, across all income brackets with the exception of the wealthiest Americans. So we can see it's about the same among higher income Americans, but otherwise we see, even among medium income, that there is a difference. So this suggests that Medicare Advantage, again, is not the solution to inequity. In our final section on Medicare Advantage, let's look at forces that influence patients to choose Medicare Advantage despite the narrow networks and hidden costs. First, Medicare Advantage is aggressively and deceptively marketed. The Senate Finance Committee issued a report in 2022 on the deceptive marketing practices used by Medicare Advantage companies, and the Senate Finance Committee continues to investigate this practice. Here is an example of a Medicare Advantage mailer that looks like a tax document from the US government. Do you see Medicare Advantage or the name of an insurance company anywhere on this mailer? Often seniors don't realize they have switched to Medicare Advantage and find out months later. And here are a few examples of television advertisements that say that seniors are missing out on benefits, including higher Social Security payments, in order to prompt seniors to call Medicare Advantage plan agents or broker hotlines. But none of the ads mention Medicare Advantage or insurance companies. Another reason to choose Medicare Advantage is the advice of an insurance broker. Brokers are supposed to help beneficiaries choose the right coverage, but they are incentivized to bring seniors to Medicare Advantage. Their commissions are significantly higher when they steer patients to Medicare Advantage plans when compared to other types of coverage. And this trend is increasing, while their compensation for other types of plans is decreasing. About 1/3 of seniors rely on insurance brokers to make these decisions. It's also important to note that brokers can continue to receive commissions for years after they enroll a patient in a Medicare Advantage plan. A 2022 Centers for Medicare and Medicaid Secret Shopper study even found that 80% of insurance broker calls provided inaccurate or insufficient information, misleading seniors. Here is a real and egregious example of a broker telling a caller, if your medication is not on the formulary, your doctor could tell the plan and the plan would simply add it. But most importantly, people sign up for Medicare Advantage because they want to save money. We know that there are problems in traditional Medicare. There is the 20% outpatient coinsurance charge, which is very expensive. There is a $1,600 hospital deductible. We know there is no limit on out-of-pocket costs for traditional Medicare beneficiaries. And that's frightening to seniors. They are left with three options. They could keep traditional Medicare and do nothing else, which would place them at a high risk of bankruptcy. They could purchase a Medigap plan, which would mean that they would be paying an additional premium up front, or they can leave for Medicare Advantage. All right, so let's explore considerations for a typical Medicare beneficiary when deciding between traditional Medicare and a Medigap plan, between traditional Medicare with a Medigap plan and Medicare Advantage. We'll use the Medigap plan, Plan G, which is one of the more popular Medigap plans, but there are many different Medigap plans to choose from. I'll put a fuchsia box around the features that are likely to be most attractive to Medicare beneficiaries. All right, so first, looking at the benefits that are received for a patient with traditional Medicare with a Medigap plan, they don't receive any additional benefits beyond what's covered in traditional Medicare. So that does not include vision, dental, hearing, reductions of out-of-pocket costs, gym memberships, none of that is included. In Medicare Advantage, this often includes additional benefits, as we've been saying. So it wraps in their Part D coverage, their pharmaceutical coverage, and these additional benefits. Taking a look at out-of-pocket costs, individuals who stay in traditional Medicare with a Medigap plan, the Medigap plan, at least Plan G, eliminates their out-of-pocket costs after they pay their Part B deductible. So this particular Medigap plan is attractive in that way. And in comparison, Medicare Advantage has an $8,850 maximum for out-of-pocket costs for in-network approved services. And what's not on this slide is that out-of-pocket maximum for a combination of in-network and out-of-network services combined is $13,000. So this can add up, and that can be hidden from some seniors who are making this decision. Okay. All right, so let's look at utilization management. So this is issues like prior authorization. So as we've been saying, utilization management is rare in traditional Medicare. So there are a few items that require prior authorization in traditional Medicare, but in Medicare Advantage, it is very common to face prior authorizations that are proprietary. So each Medicare Advantage plan will have different conditions for what they will cover, and they're also much more likely to require step therapy, that you try one medication before trying the one that you're requesting. Okay, let's look at networks. So an enrollee who has traditional Medicare with a Medigap plan has the full traditional Medicare network. So they can see all doctors who are who accept Medicare, and all hospitals. In comparison, with Medicare Advantage, as we've said, the networks are much smaller, and it can be confusing to see which services and providers are in network. And then finally, monthly premiums. So this is what seniors are paying up front. So for traditional Medicare with a Plan G Medigap plan, they're paying $175 minimum based on their income for their Part B premium. They're paying, and this is per month, $200 per month for their Plan G premium, $55 for their Part D premium. So this adds up to at least a little over $5,000 per year. And compare that to Medicare Advantage, where they pay their Part B premium, so a minimum of $175 a month, but then most Medicare Advantage plans are only about $18 a month. And that includes their Part D drug benefit. So that upfront cost is only about $2,000 per year. So as you would expect, the real deciding factor for most people is the monthly premium. So that's why many opt for Medicare Advantage. They may not be able to afford premiums for both Part B, Part D, and Medigap. So Medicare Advantage is their only option. But we talked before about the higher proportion of Medicare beneficiaries across income brackets who face financial barriers to care. So we know that lower premiums does not mean lower spending overall for Medicare Advantage recipients. All right, now that we've reviewed several downsides of the Medicare Advantage model and the real financial pressures for lower income seniors to select these plans, let's talk about alternatives that could use tax dollars more efficiently to provide more health care. First, let's take a look at another estimate of overspending in Medicare Advantage to get a sense of the money our country is theoretically prepared to spend on health coverage. Here are our considerations. All right, so there's upcoding. We talked about this, so that's adding inactive diagnoses to increase the capitation rate. This adds about $20 billion per year to Medicare spending. Then we have favorable selection. So that's letting Medicare Advantage plans take home more profit from their rebates because they have healthier than predicted beneficiaries. That's another $45 billion in overspending. And then we didn't talk about this, but there are county benchmarks and quality bonuses. I skipped over this, but these are government bonuses intended to incentivize higher quality, but there's no evidence that they've been having that effect. And that's another about $26 billion in overspending. So adding it all up, this is up to $104 billion in wasteful spending of money that does not go to healthcare each year. However, an analysis from PNHP estimated the overpayment from induced utilization as well. The overpayment, so this would be the overpayment to Medicare Advantage plans to remove financial barriers and out-of-pocket costs, but that does not occur. And that adds another $36 billion in overpayment each year. So overall, we estimate that Medicare Advantage could be driving up healthcare costs by as much as $140 billion each year. Whether we're overpaying insurance companies by a high estimate of $140 billion or a lower estimate of $88 billion as calculated by MedPAC, if Congress places more limitations on Medicare Advantage, then we could use these dollars to reduce costs and provide more comprehensive care to Medicare beneficiaries. Comparing the magnitude of overspending on the left, we see that this money could be used to eliminate or at least reduce Medicare Part B premiums. It could also be used to reduce spending on Part D medications. This has been a focus during this presidential election on the heel of the Inflation Reduction Act, including negotiation of 10 Part D medications for the first time. Additionally, a fraction of this money could be used to cap out-of-pocket expenses for traditional Medicare beneficiaries, and also to provide dental, hearing, and vision benefits to Americans on Medicare and Medicaid. So these are the costs of providing these services to both types of recipients combined. Further, addition of such benefits could attract more people from Medicare Advantage to traditional Medicare and further reduce Medicare Advantage overspending. These are just a few modest proposals to increase access to more comprehensive coverage. But what about universal health care? While a little over 50% of Americans express support for a single-payer improved Medicare for all plan, in these 2020 Kaiser data, we see 22% of Americans somewhat favor, and 31% strongly favor a Medicare for all plan. And these numbers are higher among Democrats. There is no clear path forward for the Jayapal and Sanders improved Medicare for all bills in the United States Congress at the moment. However, you may be surprised to hear that New York is closest to passing a single-payer universal plan of any state in the country. For the rest of this presentation, I'll focus on this bill, the New York Health Act. The New York Health Act would create one high-quality tax-funded healthcare plan for all New York residents, regardless of immigration, employment, income, or marital status, from cradle to grave. It would have no financial barriers to care, so it would have no premiums, no copays, no deductibles. I always try to imagine walking into a pharmacy and walking out with medication without having to pay, which is hard to imagine. It would outlaw administrative barriers like prior authorization and step therapy requirements. It would also be the most comprehensive coverage in existence, covering inpatient and outpatient care, primary care, specialty care, mental health, but also dental, hearing, vision, and long-term care. And that's both long-term care in a nursing home or at home, so all New Yorkers can age with dignity. This plan would also would replace all insurance, and it would wrap around Medicare to add these additional benefits and to cover out-of-pocket expenses for Medicare beneficiaries. After discussing the efficiency of Medicare compared to private insurance for the past half hour or so, you may not be surprised to hear that several analyses in the New York Health Act project that it would cost less while providing much more health care. Just like traditional Medicare, New York Health would save by cutting out administrative costs or cutting down on administrative costs. So the nonpartisan RAND Corporation estimates that it would save over $20 billion per year by cutting out insurance company profits and administrative costs, $16 billion per year by no longer requiring entire offices of staff members just to haggle with insurance companies to get claims paid. And we would save over $18 billion per year by negotiating for lower drug and device prices by leveraging more than 19 million covered lives in New York State. Even with increased spending on covering everyone, so about $17 billion more to cover everyone in New York State, increased spending of about $8.8 billion on improving compensation for providers, so particularly primary care. And of course, the large expense, about $18 billion of providing long-term care to all New Yorkers, which we know is driving rises in costs for most countries. We would still save about $11 billion each year. Okay, so how close are we to passing the New York Health Act? Let's remind ourselves of how a bill becomes a law. Anyone can have an idea, and then it must be drafted into a bill in both houses of the legislature, the New York State Senate and the New York State Assembly. Then it has to be voted on and passed in the relevant committees. So in this case, it would be the Senate Health Committee and the Assembly Health Committee. And then it must be voted on by the full Senate and Assembly. And finally, the governor must sign it in order for it to become a law. The New York Health Act has passed the full assembly at least 4 times, but it has never passed through the New York State Senate Health Committee. So that's where it's at right now. But given the right conditions, we could theoretically pass the bill because a majority of New York State Assembly members and senators have signed on to co-sponsor the bill. Additionally, many healthcare professional groups have endorsed the bill. As we can see here, American Academy of Pediatrics, the New York State Academy of Family Physicians, CIR, Doctors Council, New York State Nurses Association, 1199, our community health centers. While ACP and SGIM have endorsed the idea of single payer or a universal health care plan, New York, ACP, and SGIM Mid-Atlantic have not endorsed the New York Health Act. All right, so if you're feeling fired up to advocate for more health coverage, here are a few next steps. PNHP has been leading and organizing health professionals nationally and here in New York to bring attention to the problems with Medicare Advantage and opportunities to use our healthcare dollars to cover more healthcare. Check out their 2 reports on Medicare Advantage overspending and the harms for patients. And remember that open enrollment for Medicare is October 15th to December 7th. So this is an opportunity to talk to your patients about the narrow networks and hidden financial barriers in Medicare Advantage. All right, and if you're interested in getting involved, speaking up, writing an op-ed, meeting with your elected officials, discussing this further, or in talking about preventive medicine or drug user health, please send me an email at betty.kolod@mssm.edu. I have an MSSM email address, just to point that out, and thank you so much.